So welcome everybody to our second module of our intraoperative ultrasound webinar. The first module, those of you who attended, will show a brief sort of overview of that and show how what we've done now is an extension on the indications for intraoperative ultrasound. So I'd like to start off firstly by welcoming all of you. Thank you for adjusting to the new time slot. Um, Thank you firstly goes for the support for this webinar to the University of Pretoria, particularly our Department of Neurosurgery at the university, then for Europa organization for all their sort of structural and logistic support, and then support again for this webinar by BK Medical and Sonoclear. So I'm very thankful to our distinguished faculty for joining again. We have some of our previous faculty who've joined again, for those of you who've attended our previous webinar. So this is our second module. I'm going to go through our last one where we covered mostly topics on tumor surgery. We looked at contrast enhanced ultrasound, we looked at shear wave elastography, we covered quite a few things which were done beautifully by some of the same faculty. So now we're going to cover things like the role of ultrasound in pediatric neurosurgery, hydrocephalus, endoscopy, and then Professor Unsgard will talk about the vascular lesions. Aliasgar just let us know that he might be a little late. He's been called to surgery, so we'll move that talk later down. Francesco will give us a talk on high-intensity focused ultrasound, the therapeutic indications. And then we've got a particularly special treat conducted by Professor Alessandro and Francesco Di Meco, both from Italy, who've done a tremendous amount of work promoting the use of intraoperative ultrasound in neurosurgery, and they've developed quite a novel simulation training system. So we're looking forward to how that interacts, or at least how that interfaces with our current webinar. I'd also like to thank, and I'll probably leave this to Professor Unsgard, because of his efforts, we've established a potential collaboration with the CNS from the United States. So Brian Nahed and Vikram Prabhu will be joining as well. So Geirmund, I'll leave that to you to introduce, if that's okay. And then in the interest of time, I'm going to start the program off this time. So my allotted topic is the use of ultrasound in neurosurgery, particularly as it relates to pediatric neurosurgery, indications for hydrocephalus. I'll touch a little bit on the vascular stuff, particularly the vein of Galen diagnosis in children, and then how ultrasound has established itself as a navigation tool in endoscopy. And seeing as there's been about a 2-month sort of lag since our last ultrasound in neurosurgery module, but this is our third sort of safety in neurosurgery webinar from the University of Pretoria, I'm going to do a brief overview just to recap a little bit. So a lot of you would know that ultrasound applies to all sound waves with a frequency above the audible range of normal human hearing, which is about 20 kilohertz. Diagnostic ultrasound generally ranges between 2 and 18 megahertz. The more modern probes tend to go higher than that, and depending on the indication, can go upwards of 20 megahertz as well. Therapeutic ultrasound, however, ranges a much sort of lower frequency, 260 kilohertz to about 690. And Francesco will tell us a lot more about the indications for therapeutic ultrasound later on. So these waves are then reflected from the surfaces, detected by a scanner as an image. And I think a lot of sort of simplified. Tom Selbeck gave a beautiful talk on this the last time. I'm just going to give a very simple overview. I always like this slide because it highlights the fact that even though ultrasound has become synonymous with cardiology and obstetrics and gynecology now, the roots for ultrasound in medicine started in neurology and neurosurgery, in fact. So Carl Dussek was the first physician to use an ultrasound, and he actually thought that he was looking at the ventricles. And for those of you familiar with a sagittal view, you can see why he thought he was looking at the ventricles. Turned out that was actually artifact at the time, but still the first description was, for the use of ultrasound in neurosurgery. And then Ian Donald, who really drove after Carl Dussek, really pioneered the use of ultrasound in medicine, drove it in obstetrics. And his particular link there was that he did his MSc or his BA in South Africa. He did that at UCT. So the indications for the use of ultrasound in neurosurgery are growing and are quite diverse. And I would argue that there is no other imaging or diagnostic tool currently available that there's this wide a spectrum of application in neurosurgery. So if we look at the diagnostic capability, so bedside, craniosynostosis, hydrocephalus, tumors, vascular abnormalities, to name a few, and then raised ICP, which is something I've spent quite a bit of time on, but probably forms an entirely different webinar on its own. The intraoperative applications, tumors, like we've seen in our previous one, I'll touch on that a little bit, the tumors in children and some in adults. Hydrocephalus, we'll look at VP shunts, multiloculated hydrocephalus, as well as endoscopy. And then Chiari malformations, which is quite a sort of unique and peculiar indication for ultrasound guidance. The vascular stuff Professor Unsgard will do, and then peripheral nerve surgery, which is something that I don't have too much experience on, but is a growing indication for intraoperative ultrasound. Certainly a lot more published on that. And then apart from this, just the diagnostic and the navigation capacity, as a surgical tool, the CUSA, pizza surgery are all ultrasound-based devices. Therapeutic modality, which Francesco will talk about, high-intensity focused ultrasound for tumors, functional neurosurgery, and the blood-brain barrier disruption. And then something that's quite sort of unique is something called neuromodulation, the study of sonogenetics. So a study of how sound waves can be used to neuromodulate is quite an appealing research-based phenomenon. So as a bedside tool, I think the fundamentals are, in children especially, is that it decreases the amount of CT scans. So it improves our screening capacity, initial or early diagnosis in neonates particularly, follow-up assessments for ventricular size, especially in kids who've had ventricular peritoneal shunts. And you can see it's quite easily applicable at the bedside. This was a child intubated preoperatively, but the principles are still the same. At the bottom, you can see a coronal view and a sagittal view, and no other imaging modality provides one with that sort of real-time, impactful imaging that you can act on, like I said, in real time. So why ultrasound is more appealing in children? This is a typical screenshot of the PAC system in one of the leading children's hospitals. And you can see this is a 6-month-old child who had 15 CT scans over the span of 5 months. And that is not an uncommon finding. So what does that mean in real terms? So the effective dose of radiation is calculated in millisieverts. A chest x-ray is about 0.02 millisieverts, so one day's background dose of radiation. Skull x-ray, about 5 days background dose. But a CT scan has the equivalent of 8 months worth of background radiation. So one CT scan is the equivalent of about 100 chest x-rays, and at least a third of children have around three CT scans before the age of 12. And like I shown previously, a 6-month-old can have up to 15 scans. So if you look at that, this study published in the Lancet and also featured in the New York Times a few years back, looked at a huge number of patients trying to examine what the real exposure of radiation is. So any child that has 2 to 3 CT scans under the age of 15 has a triple times lifetime risk of developing brain cancer and a 3 times higher risk of developing leukemia. So you can just work out what the increased radiation dose in these children amounts to. So the appeal for a non-invasive radiation-sparing imaging tool is incredibly appealing in children. So that is its diagnostic capacity. And if we look at the modern neurosurgery theater, it's become quite an intimidating place to be. We've got sophisticated neuronavigation systems. We've got minimally invasive techniques, intraoperative imaging, MRI, CT, fluorescence guidance, intraoperative ultrasound, and then sophisticated intraoperative monitoring techniques, mapping and monitoring techniques. So the role of ultrasound in this context is quite well defined and I think growing. One needs a good machine, you need a good probe, and you need some sort of experience in using it. The ideal navigation tool should fit these sort of criteria. It should be accurate, reproducible, should be dynamic, and ideally provide real-time feedback. It should be easy to use, I think, most of all. Portable is helpful, cost-effective, and like I've pointed out, if it limits radiation exposure to the developing brain, that is a huge gain. So in my practice, I've used it now for over 500 cases: ventricular catheter placement, neoplasms intraaxially, endoscopic fenestrations for multiloculated complex hydrocephalus, used in vascular tumors as well as AVMs and vein of Galen malformations, Chiari-1 malformation, which I'll show as well, decompression to kind of have a quality control measure for when you do bony decompressions only and whether that's adequate. And then for intramedullary spinal cord tumors. I've left those out of this talk because Ali was going to talk about spinal cord tumors, but we may integrate that a little later. So what are the necessities? You need a dural window, be that a fontanelle or a craniotomy. You need sterility, which is important, and the more comfortable you become with it, the more easy it will be to drape the probe and to sterilize it. In some companies like the BK probe, you can sterilize the probe before you actually use them. Image quality, you need good spatial resolution that relates to the frequency and probe size, and the acoustic coupling. And you'll see the kind of more sophisticated gels which have been developed now make a huge difference in terms of the actual image quality. And then one's got to be comfortable with the image display. So it's usually orthogonal, dual plane, or stereoscopic, which for most neurosurgeons is counterintuitive. So it does take some getting used to, but it's certainly worth the effort. The probes, linear versus phased array probes, again, these one can't be prescriptive about. You've got to find what works best with the equipment that you have. And then most importantly is this user experience and learning curve. The more you use it, the better you get at it, and the more you want to use it, the more you practice, I think the more your level of expertise improves. So this case for me demonstrates the benefit of intraoperative imaging. It's a kid that was sent to us with a huge hemispheric tumor lining the ventricle, did what we thought was a pretty good resection, lining the ependyma, but for some reason we couldn't get a contrast scan post-op. Thought we did a good job, but you can see a little bit of sort of imaging heterogeneity over there. Did a month follow-up scan, and in that time this had grown. So this was without intraoperative imaging. And the argument there is that with sufficient intraoperative ultrasound, we may have been able to pick that up and maybe would have resected more than we'd left. So there certainly is an appeal in tumor surgery, pediatric tumor surgery, for a real-time dynamic feedback intraoperative imaging tool. Intraoperative MRI versus ultrasound, I've just touched on that briefly. Ali gave us a beautiful talk on that the last time. I think the cost comparison between the two is really is not even a comparative factor. And if you look at the quality of imaging that one can get these days, I think the argument for developing one's skill set in intraoperative ultrasound is made just by that factor and so on. So navigated 3D ultrasound, I've just touched on that, is a huge advancement, and you can see Geirmund Unsgard and his team in Trondheim have really driven that and pioneered that, and he's given us an excellent talk before, and I'm sure the one we're waiting for now will be along those lines. So this is an image that I love using because you can see the coronal imaging, the coronal MRI scan shows what is a choroid plexus tumor, which had grown in the lateral ventricle and into the third ventricle. And if you look at the intraoperative ultrasound imaging that we've got, obviously the plane one can manipulate, but you can see the quality comparison. So the tumor here versus tumor there, you can see the tumor in the third ventricle down there. The imaging quality is fantastic. And once you use the Doppler function, you can see the vasculature between the tumor becomes even more pronounced. So that's what it looks like on the scan, but in the ultrasound, you know exactly where the vessel is. So I've used it now, like I said, routinely in almost all my tumor surgeries. This is a posterior fossa tumor in a child. You can see it turned out to be a medulloblastoma. That's what it looked like pre-resection. During the resection, I removed what I thought was almost all of the tumor. The ultrasound showed a little bit of what I thought was residual. Went back, removed that, and you can see both on the microscope, that's the aqueduct. This is the floor of the fourth ventricle. Showed we'd gotten a good resection, which was exactly what is shown in the post-op MRI scan. Vascularity, I think it's incredibly useful. So this is something called the power Doppler function. It's great to show adjacent vessels. So that's tumor. These are adjacent vessels. And if you look over here, it shows tumor vessel as well. So it's quite nice to differentiate. This was the pica on both sides, and this is tumor vessel. So it's quite nice to differentiate, tumor vessel from adjacent vessels. So this is a scan again showing what we thought was a complete resection. Ultrasound suggested the resection was complete. Lined the cavity with some Surgicel, and again that was confirmed in the post-op MRI scan. This is the case where I left tumor deliberately against the brainstem because the neuromonitoring suggested that it was safer to leave behind. You can see that was confirmed, so I knew exactly what the residual was on the post-op ultrasound, and the post-op MRI scan confirmed that. This kid had obviously multiple embryonal tumor metastases, but that was confirmed. So it's quite nice to have a quality control measure that's reliable before you close. Some of the limitations, so normal saline gives you this odd sort of imaging artifact here, and some of the new acoustic coupling gels, which have been developed now, go a long way to improve that quality. And that's one of the measures that have been used to improve imaging quality. This is a study comparing intraoperative ultrasound with post-op MRI, and I think the consensus now is that you can get a greater extent of tumor resection because of the real-time feedback, and there is quite a good correlation between intraoperative ultrasound and MRI. Hydrocephalus. It's quite useful again. So that's been, they used to be found in tumors. This is the child who had a ventricular drain. You can see that there. But despite elevating the drain, the ventricles wouldn't dilate. It was a 9-month-old child, so he had a small fontanelle, but enough of a fontanelle that we could use the ultrasound to guide our catheter. You can see in the end it was quite nicely placed, and this is what it looks like under real time. So you can see the catheter being placed, entering the ventricle, sagittal plane. So you're under real time guidance all the time. So you're able to control your catheter. And then what I find even more useful than that is the ability to rotate the probe and change the plane. So you'll see at this point I rotate the plane. And what I thought was a good placement turned out was a bit too lateral. So you have the ability to correct it, and you can see the post-op scans quite good. So what do you need? There are a number of probes now. The burr hole probe, which some have found really useful. There are also other probes, high-frequency probes. I think at least 8 megahertz is probably what's useful. Whether you go transfontanelle or or via the burr hole really depends on the equipment you have and really the size of the age of the child. The newer probes now do claim to be able to image via the temporal bone. So we look forward to that. But for the time being, I mean, kids with an open fontanelle, I would argue, and I'll show that in a second, should all have some sort of navigation guidance. But ultrasound provides quite a useful alternative there. So this is just showing it is a study we conducted previously, comparing the correlation between measurements on ultrasound and CT scan, pretty good. We then used 2 ways of measuring objectively. So we used the Euclidean distance, where you actually use the 3-dimensional placement. So that's kind of scientifically more viable. But again, what's more practical is a subjective way of determining where the catheter is. So we use this criteria described by Hayhurst et al. And Martin Schumann, who was part of our faculty in the previous ultrasound webinar, published a paper which I'll show now. And this is just showing some of our results, which correlated pretty well with his. A lot of the ultrasound guided versus standard, a lot of them were placed, what was considered optimally. More of them were placed optimally, acceptably, depending on what one uses. We had a lot less of those, and none of the patients who had ultrasound guided shunts needed revision of the ventricular catheter. So this is the paper published by Martin Schumann and his group, and their recommendation, which was pretty strong, I thought. One needs to just guide that a little bit, but they said all ultrasound guided ventricular catheter placement, or at least ultrasound guided ventricular catheter placement, should become a standard of care in VP shunt surgery. Remember, this was in children. Then neuroendoscopy, I think real-time intraoperative imaging is really such a benefit in this group. A lot of people use neuronavigation, as I'll show, some combined with intraoperative MRI, which turned out to be, I think, quite a bit of an overkill, but I'll show how some of that has played itself out. So the use of navigation in endoscopy in complex hydrocephalus has been described by a few centers now. So Uli Tomale, who spoke in our pediatric neurosurgery webinar previously, published this paper. He found navigation guidance to refine operative planning and intraoperative orientation. They found that a few procedures, at least more than one, was required in these complex hydrocephalus patients. They did describe quite a high complication rate though. The Israeli group, headed by Shlomi Konstantini, who was also part of our previous webinar, combined neuronavigation with intraoperative MRI. And they found combining these 2 modalities provided very good real-time navigation. Again, intraoperative MRI is quite an esoteric intraoperative imaging device, and the high cost and logistic infrastructure really limits the widespread use. So MR ventriculography combined with that, this paper published by Gandoki, is incredibly useful. So you know endoscopically in patients who have complex hydrocephalus, intraventricular cysts, or multiloculated hydrocephalus, whether you've actually fenestrated all these compartments adequately or not. And unfortunately, this technique limits one to only knowing this sort of information post-operatively. So there's nothing you can do intraoperatively. This paper published by Martin Strovitsky really sort of drove the ultrasound-guided technique, but that was in 2002. There's not been a huge amount done since then. So I've just put these pictures up to show some of the setup that we use. This is a typical patient with complex hydrocephalus. You can see the kind of difference in intensity, suggesting that that's CSF. This is more proteinaceous. So we plan with navigation our entry points, and this is the setup in the ultrasound room. This is typically where we position the ultrasound. You can see we need more than 2 hands. So generally I have 2 assistants, one helping me with the endoscopy and one with the ultrasound probe. But one can use that to sort of flush and fenestrate, and you can see here we're removing some pus from the abscess. So this is an example of what these look like. You can see it's the only sort of real-time tool to give you a multiplanar imaging of what complex hydrocephalus looks like. This one shows this ultrasound ventriculography technique, which we've developed a bit now. You can see clearly these 2 compartments don't communicate, so we know that needs to be fenestrated. And this is a case that has been adequately fenestrated, so you can see the contrast medium goes from the lateral into the third and then into the other ventricle. So we're happy that we fenestrated adequately there. Okay, power Doppler, quite useful. Tumor vessels I've shown previously. The duplex function is quite nice. It's always quite nice to see that sort of that sort of real-time feedback. This is a kid with a vein of Llewellyn. This is an intraoperative tumor. Okay, then lastly, and I think we're running pretty close to time now. So the Chiari deformity, quickly, a lot of you know, I'm not going to go into too much detail, is an hindbrain herniation of the cerebellar tonsils, whatever the definition is, often associated with syringomyelia hydrocephalus. I think for the protocol that we've used, and similar to this one published by Naren Garasalingam, if one has a cine MRI that demonstrates no flow across the CSF, the CCJ, that's quite a useful preoperative marker that there is no flow. So what we do then is, if the bony decompression is considered adequate, we use the ultrasound probe post bony decompression, and you can see here, you can see the tonsils pulsating quite nicely. That is considered by some to be adequate, but what we've done is use the Doppler function here, and you can actually see CSF flowing around the cerebellar tonsils. So if you have the cine MRI before demonstrating no flow, and a sort of Doppler function ultrasound demonstrating flow afterwards, it's quite a useful quality control measure that one perhaps doesn't need to open the dura, because the morbidity-related step in this surgery is related to dural opening, and what you want to do is restore CSF flow. So I've integrated that into my my management protocol for this condition. So I'm going to run through these very, very, very quickly, because Francesco did a great job with them previously. Advances are 3D, contrast enhanced, strain measurement, and elastography. They will be on the PDF if you need them, but I'm not going to go through them for the interest of time. So then quickly, just to end off, this was a quote from Jay Forbes when he wrote the preface in Lennox Treatise. What he said was that this was his quote, that it will ever come into general practice, I'm extremely doubtful, because its beneficial application requires much time and gives a good bit of trouble to the patient and the practitioner. What he was talking about at that time was the stethoscope, and we know how widely used that's become. But if you sort of translate this into the sort of introduction of ultrasound into neurosurgery, it fits that same sort of thing. So I think just taking the time and the effort to learn how to use it is quite useful. So to summarize that, I think ultrasound is safe, it's cost-effective, portable, non-invasive, has diverse applications, particularly in pediatric neurosurgery, diagnostic, navigation, and as a surgical adjunct, and like I've demonstrated with therapeutic and neuromodulation implications. I think it has incredible diagnostic and therapeutic potential in the next few years. So it's certainly worth us as neurosurgeons, pediatric or adults, making the effort to integrate this modality into our routine practice. And with that, I'd like to thank you. Okay, Clay? Hello?
Hello?
Clay, can you hear me?
Yeah, hey.
Okay, Geirmund. So I think you're up next, and
Yeah.
most all of you would remember Professor Unsgard is a real pioneer in this field. He spoke in our previous webinar, and we're really honored to have Geirmund talking again now. Geirmund, so I'm going to let you go ahead and talk to us about ultrasound in vascular lesions. Thanks, Geirmund.
Yes, thank you, Llewellyn. You challenged me to tell a little bit about this international group that are doing education all over the world. We started in Mumbai, and we were going to make some course in Pretoria. But that due to the corona, that turned into these two webinars. And we are also very thankful to Brian Head and Vikram Prabhu that we were invited to do some education at the CNS. So we are looking forward to develop that together with them. Well, I'm going to tell about ultrasound-guided surgery for vascular lesions. Ultrasound can depict vessel in different ways, power Doppler, color Doppler, contrast-enhanced ultrasound. In contrast-enhanced ultrasound, you need to inject contrast in vessels, and you need a special setting on the ultrasound machine. In color Doppler, it shows the blood flow, and the color indicate whether the direction is towards or away from the probe. I've been using power Doppler. It has a high sensitivity, good images of small vessels, and it's not dependent on the probe position. And so it's very suitable for 3D ultrasound angiography. To make the images, we used the Sono 1, which integrates navigation, neuronavigation, and ultrasound. The probe is moved over the area of interest, and the 3D ultrasound volume is fused into the neuronavigation MR volume. And then to show display the information, cross-sections from the 3D ultrasound volumes and corresponding cross-sections from the neuronavigation MR are steered by either a navigator, a pointer, or a navigated microscope. The first lesion I'm going to talk about is cavernoma. It's a cluster of small irregular vessels that bleed and cause epilepsy sometimes. The blood flow in these lesions are very slow, so it's not depicted by angiography, but it's very well seen in B mode. This is a small movie showing an operation of a young lady that had a cavernoma, and she had also a very severe epilepsy. And this is the way I will do it. Make 3D ultrasound. It can be done in different ways, of course. Make 3D ultrasound and then point with a virtual pointer in the middle of the image of the cavernoma and put a target there, a virtual target. And then use the microscope as a navigation pointer. And then the crosshairs of the microscope will guide you down to the lesion. You only use two very small spatula, open up a little bit. It's very easy. And then you go directly to the cavernoma, remove the cavernoma. It's easy to remove these cavernomas. They usually don't bleed. Then immediately, when you have removed the cavernoma, you do a new ultrasound angiography, ultrasound image to show that everything is removed. So you don't have to go in there and fuss around with some spatula to look. You can see it immediately in the image. And you see there's a very small access to this cavernoma. Yeah. And sometimes there is a discrepancy between the neuronavigation MR and the intraoperative ultrasound, even before you really start the operation. Then you should always trust the intraoperative ultrasound. And this is how I operated this one. After some time, I thought I was finished, but there was some control showed that there was some residual cavernoma. And then at the end, everything was removed. This patient, this young, not so young, but a lady with a hemiparesis and also affection of the 5th, 6th, 7th, and 8th nerve. And all symptoms were progressing rapidly. So I had to operate her. And of course, the shortest way would be through the floor of the 4th ventricle. But that would certainly be a catastrophe. The way to operate this is to go laterally between the 5th and the 8th nerve and through the normal brainstem and you aim into the middle of the image of the cavernoma. Then you can remove this very smoothly through a very small opening. And immediately after removal, you do an ultrasound image to show that everything is removed. And that was confirmed on MR the day after the operation. And 5 weeks after the operation at the outpatient clinic, there was no symptoms at all. The patient had no symptoms at all. There is a lot of information in the ultrasound angiography. You can see that by comparing a rendering of the MR angiography and an ultrasound angiography of a patient with a media aneurysm. It looks very much alike. And how can we use this information? You can make a 3D ultrasound angiography and then point to the aneurysm. You see the aneurysm here. And after clipping, you do the same, and then you point to the aneurysm. You see that it's clipped, well clipped. And you point to the frontal M2 branch, and you see it's good circulation in it. And you point to the temporal M2, and it's good circulation in that as well. So you know it's no problem with that clipping. Yeah, this is a patient that had also a media aneurysm. Aneurysm is exposed. You make a new ultrasound angiography and show the aneurysm, and then you put a clip on this aneurysm. And you see this is not well clipped actually, but I took off the temporal clip and then did a new ultrasound angiography. There is a small flip there. You can see this small flip. And then I put the fenestrated clip on it. And then I did a new angiography. And here you see the flip is gone. So now it's well clipped. So you can use this 3D ultrasound angiography to evaluate the clipping. Of course, if you don't have a very expensive filter and can use fluorescence. You can also use it to localize an aneurysm in a large hematoma to be able to safely remove some of the hematoma to gain space. I've done that a couple of times, but it's always a lot of tension in that operation, so I forgot to make images. And you can use it to localize aneurysm. Most of aneurysms are easy to localize, but sometimes it's nice to have this information to localize the pericallosal aneurysm. There are tumors where it's good to know where the exact position of certain vessel is. Giant meningiomas, skull-based tumors. I did a series of 15 giant meningiomas by subcapsular resection guided by navigated 3D ultrasound and 3D ultrasound angio. This is one case, very large olfactory grow meningioma, and you see the pericallosa vessel. As you gradually remove the tumor, the pericallosa vessel is changing position, and it's nice to know where it is. In this large falx meningioma that enclosed the pericallosal artery, it was very useful to know the exact position of the pericallosal artery by the 3D ultrasound angiography. All 15 patients with giant meningiomas experienced postoperative normalization and improvement of their symptoms, and no harm to normal tissue as evaluated by diffusion-weighted MR images 1 day after the operation. So it's a very gentle technique to remove these large meningiomas. Sometimes in skull-based tumors, like this chordoma that I did through a Dolan's approach to the cavernous sinus, it was very useful to know exact position of the carotid artery. I have I have operated for a long time AVM patients assisted by navigated 3D ultrasound angiography. And I became very much fond of this technology and technique, and eventually I wouldn't do an operation without it. The latter part of my material I published in 2016. It was 68 patients consecutively referred to our hospital. Some of them were not offered operation because of high risk, grade 5, and significant comorbidity. 33 patients with small AVMs in deep-seated regions were treated with gamma knife. And 31 patients were treated with microsurgery assisted by navigated 3D ultrasound angiography. And these are the patients I'm going to talk about. The method is to identify and clip the feeder based on 3D ultrasound angiography. 3D MR is not precise enough because of the brain shift. You can see here, this feeder, it's easy to localize in this image, but in the corresponding image of the MR angiography, you don't even see the feeder. Set target on the feeder and aim the navigated microscope on the target. And the microscope then will know the direction and distance to target. So you can follow the crosshairs of the microscope down to the feeder and then put a clip on the feeder. And clip the feeders and then do a new 3D ultrasound angio to see if there is still circulation in the nidus. Sometimes it is an undiscovered feeder that appears. This is an AVM with one big feeder. I clipped on that one here, and I didn't even touch the AVM before I had clipped this feeder. And you see there is a huge reduction in the AVM blood flow. And that makes it much easier to do the operation. The nidus is resected based on navigation in 3D ultrasound volume before clipping, because then you will know exact the borders between the AVM and the normal tissue. Of course, there are some perforators that have to be coagulated. And at last, I do a 3D ultrasound angiography to control that all AVM is removed. This is an AVM with 3 feeders. After clipping of these 3 feeders, there was very little circulation in the AVM. And this is how it looks like after removal of the AVM. This is a small movie of subfrontal AVM. You see here the numbers are on the feeders that I clipped during the operation, the planning, and then the angiography showing the AVM. This is one feeder that was identified, and eventually put the target on that one, adjust the microscope, go down with the microscope and place a clip on this feeder. The same was done on a second feeder. And then I thought I was finished. And I did the ultrasound angiography. And then it turned out that there was a third feeder that supplied some of the AVM. So I put a clip on this feeder as well. And then I did a new angiography showing that everything looked fine. This is a pericalosa vessel. So there is no circulation actually in the AVM. But I did the resection based on of the IOUS based on a previous AVM, previous angiography. And then I did the control, showed that everything was removed, no residual AVM. And that was confirmed also on the DSA some weeks after the operation. The results, 2/3 of the patients were grade 1 and 2, and 1/3 were grade 3 and 4. And about 50%, half of the AVMs were in eloquent location. On the workup before the operation, we identified 68 feeders, and 67 feeders were clipped based on the navigated 3D ultrasound angiography. There was no serious procedural complications. In 4 patients, I had 4 patients acquired a permanent deficit after the operation. 2 had a quadrant anopsy, that was a grade 3 and a grade 4 patient. 1 epilepsy, and 1 had a reduced motor control. He had an AVM in precentral gyrus. So all patients had a DSA about 3 months after the operation, 100% radiological cure, no residual AVM, and normalization of vasculature was confirmed in all cases. So navigated 3D ultrasound angiography is a helpful tool to identify and clip AVM feeders, and it gives good clinical and excellent radiological results. Thank you.
Thank you, Geirmund. As before, that was an absolute masterclass, and I think you've made the point for ultrasound-based angiography very well. If it's okay with you, I'm going to move straight on to Aliasgar's talk. Ali's managed to join us, but I gather he has to move on to Ali. I think you've got surgery waiting for you or something like that. So Ali, quickly from our previous ultrasound module, Ali's a very experienced tumor surgeon at the Tata Memorial. He gave a fantastic talk previously on brain tumors, and we look forward to his talk today on intraoperative ultrasound used for spinal cord tumors. So Ali, please go ahead.
Right. Good day, everyone. Thank you, Llewellyn, and thank you to the entire team for having this fantastic series of webinars. Uh, this time in the webinar, we are focusing on the expanded indications of intraoperative ultrasound. We discussed a lot about brain tumors the last time, and my brief is to talk about the role of intraoperative ultrasound in spinal tumors. So intraoperative ultrasound in spinal tumors doesn't appear as glamorous as it does in cranial applications, but there is a definite space for intraoperative ultrasound in evaluation of spinal pathology intraoperatively and specifically spinal tumors. And I'm going to run through how this has evolved and where it stands today. So when we talk of spinal tumors, all of us know that they are classified based on the plane of origin as extradural, intradural, extramedullary, and intramedullary. Most of the tumors that we would deal with are intradural tumors, both intramedullary as well as extramedullary tumors. And extradural tumors comprise a rather smaller percentage of tumors encountered in general neurosurgical practice. Surgery remains the mainstay for spinal tumors, and most often it's for excision or debulking of the tumor, and sometimes it's for obtaining tissue diagnosis or a biopsy. In any case, the challenges that we face while planning surgery and executing the surgery for spinal tumors starts with localizing the tumor, both the level of the tumor in the spine and the plane in which it lies, that's extradural, intradural, or intramedullary. Whereas it may be evident, a lot of the times, the plane sometimes is a little foxing, and the level, though it can be calculated well on the preoperative MRI, is often, and a lot of us have faced that intraoperatively difficult to find during surgery. And not only the exact level of the lesion, but the extent, especially in long segment tumors. And this has a direct bearing on the exposure that is going to be required. The exposure needs to be sufficient. At the same time, it does not need to be over ambitiously big. Coupled with the need for neurological preservation and mechanical stability. Neurological preservation is extremely important in spinal tumors because the spinal cord is much, much, much more eloquent than the brain, because of there is probably no redundant or sacrificable element in the spinal cord. And the problem of mechanical stability or instability is something that we don't deal with when we talk of cranial surgeries. Therefore, in order to address the localization issues, its anatomy, preoperative imaging, and of course, intraoperative imaging, which is going to be very useful. And this is where intraoperative ultrasound comes into play. But functional anatomy and intraoperative monitoring is extremely critical in spinal cord tumor surgeries. And this goes hand in hand with any intraoperative imaging that you would use. And then, of course, there are issues related to biomechanics and instrumentation, which is beyond the scope of this talk. Focusing on the intraoperative ultrasound applications in spinal tumors, just to give an overview that intraoperative ultrasound has been around in neurosurgery for a long time. And we saw that in the last webinar when we discussed that it was one of the first intraoperative applications of any imaging modality and in any surgery. And this was in the mid 1950s. However, that was a time when there was a development of ultrasound technology, which was essentially A mode, but it was with the advent of B mode ultrasound imaging, that is brightness mode, what we nowadays know as 2D ultrasound grayscale imaging, which provided the impetus for all applications of intraoperative ultrasound imaging. And with respect to spinal cord tumors, it was probably Reed who first demonstrated the role of ultrasound in localizing a spinal cord tumor. This was, however, done transcutaneously preoperatively in a patient using an interlaminar window. And these were the images that they were able to demonstrate. And this was, remember, in the 1970s. This was a transcutaneous application. by asking the patient to sit with the neck flexed so that it opened up the interlaminar space, and the cystic astrocytoma was demonstrated. Not very easy to appreciate, considering that we are used to such excellent image qualities these days. However, this was proof of principle that it could be used in intraspinal cord tumors. And then another 3 or 4 years lapsed before it was actually implemented intraoperatively by neurosurgeon Llewellyn in a series of intradural tumors. And these were some of the tumors they described, and they used different transducer frequencies, and they found that the higher frequency was what was useful. And this is important. We'll see that later on in the technical aspects, because it's a superficial imaging where you would use a higher frequency probe. This was what Llewellyn demonstrated, and it looked very good, the images. Following that, there was a spate of publications which described the use of intraoperative ultrasound in different tumors. The largest of these series, and till date I think it's still the largest series, coming from Epstein's group, Fred Epstein, and they demonstrated it's used in almost 200 intramedullary tumors. Simultaneously, there were publications from the Nagoya group in Japan, both intradural tumors as well as intramedullary tumors. And since then, there have been many series which describe the application. These have paved the way to demonstrate what are the technical parameters that are optimal in intraoperative ultrasound imaging for spinal tumors, as well as characterization of the tumors and the utility of intraoperative ultrasound in the form of localization as well as resection control. This is not an exhaustive list, but this is representative of what has been published. Just to reinforce that it's not just tumors that the intraoperative ultrasound would be useful in, but as Llewellyn has shown, and there are many other applications in spine, including dysraphism, trauma, vascular, we saw that in the previous talk by Professor Unsgard, and in degenerative spine disease too. And this has also been used and published extensively in the literature. Nevertheless, the application for tumors remains one of the most widely implemented applications of intraoperative ultrasound. And in this report of a large number of intraoperative applications in different spinal pathologies, also 90% of the applications were for tumor surgery. And interestingly, there was a significant change in the intraoperative decision-making based on the results of the intraoperative ultrasound. And we'll see that a little later. So the backbone of implementing intraoperative ultrasound in spinal tumor surgery is to understand the intraoperative ultrasound appearance of the normal spinal cord. And this was very nicely described by the initial publications in the 1970s and 80s, and this led to the understanding of normal spinal anatomy based on ultrasound, and therefore subsequently pathological anatomy or pathology. So you must remember that the dura appears hyperechoic on the intraoperative ultrasound, and within it is suspended the anechoic or hypoechoic CSF, within which lies the normal spinal cord. The surface of the spinal cord is also reflective because of the physical phenomena that happen when ultrasound passes through CSF and then hits the spinal cord. It's basically interference which happens. And the spinal cord is homogeneous. However, it has different appearances at different levels: cervical, dorsal, conus, and below that the cauda. And the central canal is visible as a bright hyperechoic spot. The exiting roots are also hyperechoic, and this is something which is important, especially when you're operating in the lower lumbosacral region. These are some of the images published by some of the early people who worked a lot on intraoperative ultrasound. This is what we meant by the dura being hyperechoic, CSF on either side, this is a longitudinal section, and the spinal cord itself having reflective hyperechoic surfaces. This is the transverse section of cervical spinal cord showing the same findings. And as you go a little lower down towards the conus medullaris, you can see the central spinal cord surrounded by the exiting roots, which start appearing bunched up towards the L1, D12, L1 region. And finally, in the chora equina, the roots appear to be clumped, but well delineated from each other and separated by CSF in between. Knowing the normal anatomy is very crucial, as I said, to understand and interpret spinal anatomy and pathology. So what is the actual utility of intraoperative ultrasound in spinal tumors? We talked about the challenges that we face during spinal cord tumor surgeries, and what the intraoperative ultrasound and intraoperative imaging in general helps is to identify the level, as we said, of the tumor, as well as the extension of the peritumoral cyst or the syrinx, which is also important to address. It also helps localize the extent of the tumor, especially in long segment ones. Important to diagnostically evaluate the tumor sometimes, though pathology is the final gold standard. Certain characteristics on intraoperative ultrasound are helpful. And then, of course, also vascular anatomy, which can be interrogated very well with the intraoperative ultrasound. And we've seen that in the previous lecture for cranial imaging, and the same applications hold true for spinal imaging. And then, of course, to look for resection control. The anatomy of the spinal cord and the pathological anatomy of different tumors is also very well known, and I would not spend too much time on this because this is something which is available. However, what is important is to acquire a good intraoperative ultrasound, because that is something which is crucial to act upon intraoperatively. If you have a good scan, then you would be able to interpret and act on the information that you have. Now, the spinal cord exposure usually is very small, especially in the transverse dimension, and therefore you have to have a probe which is going to fit into that particular exposure. Also, we're going to be insonating from very close to the surface of the spinal cord, and the spinal cord dimensions are not very big. That means that you have to have a probe which has good resolution in the superficial plane, or the first 2-3 centimeters, and therefore you would prefer to use a high frequency probe in 8 to 10 or 12 megahertz. Now, the spore probe can be sterilized. There are probes which can be sterilized. However, there are others which may not be possible to sterilize, but they could be put into sterilized drapes or covers, and you have to ensure there's good acoustic coupling by placing sterile gel. And the surgical field has to be filled flush with saline so that there is good acoustic coupling and no impedance. Also, high frequency probes are the best. People have tried to look at using 3D probes. This is not 3D reconstruction, but actual 3D probes in spinal cord tumor surgery, but that has not shown good resolution. And the best probes to use are the high frequency linear probes or the curvilinear probes, which will give you very good resolution at superficial depth. The Doppler application is also very useful in spinal cord tumor surgery, because not only does it show you the anatomy of the large vessels which are around the spinal cord, especially when you're operating high up in the cervical spine at C1 or C2, where you would want to visualize the vertebral artery within the soft tissues. Also, for certain feeders for tumors like hemangioblastomas, or even intratumoral vasculature in certain highly vascular tumors. Interestingly, and I just wanted to show this to show you that the Doppler application can go beyond just vascular imaging. But for example, in arachnoid cysts, which are sometimes extradural or intradural, and it's difficult to find the fistula which is feeding that arachnoid cyst, and there is this publication which showed the use of Doppler in identifying the flow, and which was even not detectable on the preoperative MRI. Our experience is in around 43 cases of spinal tumors which we've operated over the last many years. And as you've seen, it's a mixture of tumors where we've attempted resection and debulking, and some were only a biopsy. The primary role of the ultrasound was for localizing the tumor, but also for resection control in some of them. And most of the tumors were intradural tumors, intramedullary being the commonest, intradural, extramedullary the next group, and the extradural were very few. And the histological spectrum is comprises all possible tumors of the spinal cord. Just to give you representative tumors and how the ultrasound helped, we'll discuss a few cases. This is extradural lesions. Now, this was a 24-year-old young male who presented with rapid progressive asymmetrical quad equina syndrome. And his MRI revealed this block-like lesion sitting from L3-4 all the way down to S1. And it was enhancing diffusely and seemed to be constricting the entire lower quad equina. On the axial images, you could see that it was draping ventrally and seemed to be squeezing the entire thecal sac. We were suspecting some kind of either inflammatory pathology or hematopoietic cell tumor, because this was a very rapidly progressive pathology. At surgery, after doing a laminectomy, we found extremely stenotic thecal sac. And when we did the ultrasound, you can see here, this is what the ultrasound, so reading the ultrasound from here, this is the thecal sac with the bunched up roots of the quad equina. You can see that they are constricted because you can't see much CSF between them. And this is the tissue which is ventral to the dura. This is it. This is a still from there. And this is what we biopsied. And this we biopsied and did a wide circumferential decompression. We could not excise the whole thing. And interestingly, the histology was a very, very unusual tumor, lymphoblastic leukemia, stroke lymphoma. These are high-grade B-cell blastic leukemias. And the patient actually had a very good clinical recovery and is now being planned for adjuvant therapy in the form of chemotherapy. Then we have intradural extramedullary tumors. Now, this was another young male who presented with a slow onset of low back pain and left foot weakness. And he had mixed radiculopathy, which was asymmetrical again with sphincter sparing. This was what the MRI showed. And this is looks like a lesion arising from the tip of the conus, extramedullary intradural. And there is some other lesion similarly seen lower down in the sacral canal. And if you see in the contrast, you can appreciate the enhancement of this lesion arising from the conus exophytically, and another lesion over here. This is our clinical suspicion was a myxopapillary ependymoma. When we did a wide laminotomy, what the ultrasound helped us was to identify the conus lesion. This was how it looked, and this you can see on the ultrasound, the edge of the conus lesion along with the roots. It showed us all the bunched out thick roots, and actually all the roots were draped by tumor, which was spilling over onto the perineurium. And then we also were able to pick up the lower lesion, which was a drop metastasis, and this is these are the roots, and then this is the upper edge of the lower deposit, and we were able to remove all of them. Histology was a myxopapillary ependymoma, and the patient was offered radiotherapy after that in view of disseminated disease. This was an extramedullary query intradural tumor. We're not sure what it was. This lady presented with a long-standing history of paraparesis, and there was diffusion restriction on the MRI. What we found intraoperatively was very interesting. It was a hybrid tumor which seemed to be arising from within the cord substance and then spilling over extramedullary, and it was an epidermoid tumor, a very unusual tumor in the spinal cord. This is how it looked like. This is at the end of surgery when we were able to excise the entire lesion, and the post-op MRI showed that. Unfortunately, the patient did not make a very great recovery immediately and is still under follow-up because of a long-standing preoperative deficit. And finally, intramedullary tumors, which is where the intraoperative ultrasound is very useful. This was a young lady with progressive quadriparesis with sphincter involvement. You can see that there is an enhancing lesion in the cervical spine, and the cord at surgery was distended. The ultrasound is very useful in delineating the extent of the tumor, both in the craniocaudal as well as in the transverse dimensions, and to understand where to make the myelotomy. And this was an astrocytoma which we were able to subtotally resect. Of course, intraoperative monitoring is crucial over here. The ultrasound is a useful adjunct, but the extent of resection is governed by the intraoperative neurophysiological monitoring. So the ultrasound is useful, but there are certain limitations, including lack of orientation and a limited field of view. The spinal cord is more fragile than the brain, you must remember that. And there may be a lot of artifacts that may arise, which is why it's important to be technically correct and use the right techniques while acquiring the ultrasound. There is, of course, a lot of exciting work in intraoperative ultrasound imaging technology, which is happening, which is likely to improve these the results and the outputs of imaging. Navigated ultrasound in the spine, we use a lot of it in the cranial applications, but it's only just evolving in spine. It's a work in progress where it could be fused with CT and MRI, thereby improving orientation as well as anatomical delineation, with the advantage of having a real-time intraoperative update. There is also huge potential in contrast enhanced ultrasound imaging in spinal cord tumors, where sometimes the tumor boundaries are not very well seen, but on contrast application, there is always a better delineation of the tumor boundary, which could be useful in resection control. And finally, elastography, which is basically a different way of using ultrasound waves to interrogate tumor consistency. Basically, you're looking for stiffness of the tumor by using a technique of elastography. And this has been proof of principle studies in preclinical studies. And hopefully more work will evolve in the future to have show its relevance in the clinics. So to summarize, the role of intraoperative ultrasound in spinal cord tumor surgery is multifactorial. It is very useful for localizing the lesions, especially small tumors, but also for localizing the extent of the tumor and to look at the normal anatomy vis-a-vis in relationship to the tumor. This can govern the extent of the laminectomy, the dural opening, as well as the localization of the myelotomy, and can help delineate the plane in certain kinds of tumors and to control the resection of the tumor and in detecting any inadvertent residue. Of course, there are limitations, but applications of advanced ultrasound techniques is likely to overcome a lot of these hurdles and probably improve the efficacy of intraoperative ultrasound in spinal cord tumor surgery. Thank you very much, and that's the end of my presentation. Thank you, Llewellyn.
Thank you, Ali. That was just exceptional. Thanks for giving us that overview and sharing your experience. I'm going to stop for a second and just take some questions before we move on to Francesco's talk. So one of the questions we have is by Dr. Van Eyck. So I'm going to ask him to unmute himself and ask the question himself. Dr. Van Eyck.
Good evening. Thank you for the standard of the talk. It's really amazing. My question is pertaining the use of intraoperative ultrasound in assessing for gross tumor removal, if we can safely rely on the ultrasound versus post-operative MRI. The question is asked in aiding to reduce cost cumulative for the patient post-operative. And I know that ultrasound is operator dependent. Thank you.
Right. I think that's a very valid point. So intraoperative ultrasound is certainly cost effective. In terms of intradural extramedullary tumors, I think the role of intraoperative imaging is more for localizing the tumor, because the residue is not an issue unless, it's like the case which I showed you, there are drop lesions where you want to find all of them, and that's where it's very useful. The resection control is more or less exclusively for intramedullary tumors, where you want to remove the entire tumor. I have no personal experience in intraoperative MRI, and I can't say that, but I'm sure that the intraoperative ultrasound is logistically much more convenient, both for the patient and the surgeon. But also that here we have to keep in mind, as I already mentioned, that more than the intraoperative imaging, it's going to be your intraoperative neurophysiological monitoring, which is going to dictate how you're going to be, how much of the tumor you're going to be removing. Tumors like ependymomas, well delineated, you may not need intraoperative imaging once you've localized the extent of the tumor. but you would be governed by how your D waves are doing and your MEPs are faring. Diffuse astrocytomas, I don't think there is any way that you're going to be able to remove more if your MEPs or D waves are failing. And therefore, I would say that yes, both intraoperative ultrasound and MRI are useful, ultrasound being more cost effective and logistically more convenient, but the deciding factor is going to be intraoperative neurophysiology.
Thanks, Ali. Any of the other faculty want to respond or add some comments? Okay, so perhaps if I could just ask a quick question to you as well, Ali. So, I mean, apart from the frequency of the probe in the spine, you know, the type of probe you use is very limited by the size of the laminectomy. What sort of probe do you prefer? Is it that sort of hockey stick probe or the curved array, curvilinear type probe?
Right, I think excellent question, Llewellyn. So I think the hockey stick probe, which is a very versatile probe, especially for these kind of applications, is very useful. I use the hockey stick probe, but I also use it could also be a flat linear probe with a smaller footprint, usually 2 centimeters, 2.5 centimeters is good enough. The hockey stick probe is very useful to manipulate and maneuver within the deep cavity if at all that's needed. So in general, it should be a linear probe and a hockey stick probe or a flat linear probe, which is what with a small footprint, which is what I would use.
Okay, thanks, Ali. That's incredibly useful. So moving forward, I'm going to make 2 announcements. The one is that Claire's just posted the link, the NeuroStream link, and that relates to Alessandro Perin's simulation talk, which will follow after Francesco Prada. So for those of you who haven't registered, please register, and Alessandro will guide us through how that works when he gives his talk. So next up is Francesco Prada. Francesco gave an excellent talk in our last webinar on the sort of more esoteric, complex uses or advanced rather uses of ultrasound. He spoke about contrast enhancement. He spoke about elastography. Today he's going to give us a talk on something that he's got incredible insight into, HIFU, high intensity focused ultrasound as a therapeutic modality. So thanks, Francesco. Please go ahead.
Thank you, Llewellyn, for your kind introduction. Yeah, so as in the last time, I had to talk about something a little bit different from the topic of the webinar, which is the use of ultrasound for therapy instead of imaging, or maybe the combination of both, because ultrasound can be used for therapy guidance as well. And yeah, this is something an interest I developed in the last years, spending time at the University of Virginia through the support of the Focus Ultrasound Foundation in collaboration with my home institute in Milan. It's pretty intuitive why someone interested in ultrasound imaging can be interested also in the application of ultrasound for therapy, because there is an overlap of these 2 modalities. Ultrasound are used for therapy in many organs already, and it's a matter basically of how we deliver the acoustic energy. For imaging, we use frequency between 1 megahertz and even 70 megahertz now, whereas the frequencies used for treatments are much lower. Also, the intensity is much different, because we can use very high intensity ultrasound in terms of energy with 2 orders of magnitude of watts per square centimeter, and the duration as well is much higher, because for imaging we use very short pulses, whereas for surgery or other ultrasound therapeutic modalities we can deliver continuous energies for up to seconds and sometimes minutes. And these parameters and these differences entails different biological effects. So when we perform imaging, we don't have any biological effect, we just have a reflection of the ultrasound that creates an image. But when we use high energies and we use high mechanical indexes, we can create lesions in tissues. They can be thermal, they can be mechanical, but they're still lesions. In between, there are some transient biological effects, such as, for example, blood-brain barrier opening or neuromodulation. And as this is another way to describe this, so we can have a thermal rise, we can have a mechanical rise. And here you can see that the limitation that the diagnostic machine are keep them from causing damages, because we can actually cause damages to the tissue with ultrasound. When we talk about focus ultrasound, the idea is slightly different. It's similar to radiosurgery. We don't use planar waves. We use waves that are intersecting. And the biological effect is performed only at the intersection of these beams. The first studies about focus ultrasound were performed in Urbana, Illinois by the Fry's brother. Here you can see the device that they used, where basically they had 4 ultrasound transducer with a focal spot that was targeted on the brain, in this case of a primate. And this was performed after a craniotomy. And they were able to create thermal lesions. And they gave rise to what we can call now neurosonic surgery. Nowadays, there are many different therapeutic ultrasound devices, I would say, instead of focus ultrasound device, because they're not all focused. They can generate different focal spot in size and in shape, but they are all really, really precise. And we have also many different arrays specifically for different organs, from prostate to brain to the abdomen for uterine fibroids, for example. And there are similarities with ultrasound scanner, because I just said there are different transducers for different organs. We can use different frequencies for different applications, and also the acoustic sequences that we can employ. As I just mentioned, they can generate different biological effects. But when we talk about the brain, there is a major hurdle, which is the skull. As you all know, at least those that perform the transcranial Doppler, you know that the bone absorbs 90% of the acoustic energy. It reflects the energy, and also it deflects the beams, the ultrasound beams. So how can we solve the skull problem? So the idea is, the first idea is to perform transcranial ultrasound, which would be, of course, incisionless, which actually is incisionless, and it's very, very appealing for that. A sort of in-between transition modality could be the use of implantable devices. So transcranial sonication is a reality already now. Here in the picture you can see the helmet from the Insightec device, which already has some FDA-approved and CE-approved applications. Or there are under development, but they are not commercially available. There are navigated focus ultrasound devices. The problem with these modalities is that either you need an MR guidance, or you can have just a navigation guidance, but still you have to take into account the aberration generated by the skull. And this necessitates a phase correction. Of course, I cannot explain the equation here, but you can see from the drawing that you have to synchronize all the beams in order to focalize them precisely in a specific spot. Which, when it happens, is great news, because here on the left, you can see how the focal spot, the shape of the focal spot without phase correction. On the right, after phase correction, the focal spot, which is the purple-blue area, is much tighter, and also the acoustic pressure that we can deliver and generate at the focal spot is much higher. So it is very important, but it's really a a very complicated and cumbersome process. Another interesting modality is the use of implants. So there is a group in France led by Professor Carpentier in Paris. They developed a device called SonoCloud, which basically consists of an ultrasound transducer that is implanted at the time of surgery, at the end of surgery. This has been performed for brain tumors, but now it's under study for, I think, Alzheimer's as well. And the idea is to activate, when needed, the ultrasound transducer using a transdermal needle, delivering within the skull the acoustic energy. And they used it in combination with a microbubble for BBB opening in brain tumors with good results, very good results. The other one is to use and create an ultrasound transparent windows, always also implanted at the end of surgery. This is something that I'm developing together with Professor Di Meco in our hospital. And the idea is to use this ultrasound transparent prosthesis after the surgery for follow-up and therapy. These are some preclinical results in terms of imaging in a pig model, where you can see the prosthesis here, and the two images are without and with the prosthesis, and all the anatomical areas are clearly visible. And we also did a characterization of the prosthesis for focused ultrasound, and we found that there is a very, very slight attenuation in the order of 10% without distortion of the focal spot. We also performed some BBB opening in this ex vivo, in vitro isolated Guinea pig brain. So we managed to perform microbubble imaging through the prosthesis. And also, we managed to perform blood-brain barrier opening through the prosthesis. So in this gray area, this is where we are going to shoot the therapeutic ultrasound, and you see how the microbubble interacts with the ultrasound partially disappearing. This is a matter of how the perfusion goes. But in the end, in both cases, without and with the prosthesis, we were able to open the blood-brain barrier immediately, and this was assessed immediately after the treatment. And also, we implanted the first patient with the prosthesis, and in human, we were able, I mean, the prosthesis didn't doesn't provide any artifacts, and we were also able to perform both grayscale demoed imaging and microbubble imaging with a great accuracy. So now I would like to give you an overview on how, I would say, therapeutic ultrasound rather than focused ultrasound can be applied to some pathologies, or they can be translated into practice. So we have, as you can see, in terms of intensity and frequency that we use, different biological effects. So the most widely applied is the thermal effect, where we can concentrate continuous ultrasound wave in a focal spot, generating heat because of the friction of the molecules. And this is how the lesion is generated, and this is the shape of the focal spot in a phantom. There were the first studies were performed at Brigham's by Professor McDonald on malignant glioma, and by Professor Jean Monod in Zurich for ablation of the central median nucleus in the thalamus for neuropathic pain. The problem with this array is that the energy can be sufficiently enough collimated only in this green area that you can see in the MRI. So the treatment envelope is limited to the central areas. Therefore, the use at the moment and the application are mainly for lesioning for movement disorders such as essential tremor, Parkinson's disease, dystonia. There are some other applications such as neuropathic pain, OCD. and dystonia. But these are trials and they are not approved yet. The only approved application for at the moment is for tremor, mainly essential tremor. The first attempt was performed by my mentor at UVA, Professor Jeff Elias, in 2012. And this is the pivotal paper where they show that the safety and efficacy of focused ultrasound for essential tremor, and then this led the way to approval by the FDA. In terms of medium intensity or reversible effect, we can talk about blood-brain barrier opening. Here you can see how the ultrasound can be targeted within the brain. Then both drugs and microbubbles can be injected. The idea here is to open the blood-brain barrier in order to deliver therapeutic agents in the brain. When the microbubble, as I showed before in our preclinical setting, are hit by the ultrasound, they start to vibrate, and this vibration causes the sort of opening of the tight junctions, allowing drugs and substances to extravagate into the interstitial space. And a year ago, the first in-human trial in Alzheimer's patient was published by Llewellyn Heinen at Toronto University, Sunnybrook. Low intensity, two very interesting applications are neuromodulation and sonodynamic therapy. So neuromodulation basically is consists in the use of very low intensity and frequency pulses. And these interactions of the ultrasound with the neuronal membrane cause an alteration of the ion channels that is able to generate active potential, or with other patterns to silence them. And this is a paper published by Professor Wyn Legon, and he showed that the focal spot is very tight and can be delivered also very deeply, which is an advantage over TMS. Lastly, sonodynamic therapy is another good example on how ultrasound can be used for therapy. This consists of the interaction of the ultrasound at low frequency and low intensity, but for a long time, with a sonosensitizer. And there are a lot of studies, preclinical studies on 5LA and ultrasound in gliomas, where they showed a very good control of the disease in a preclinical setting. We performed at UVA a safety study, and we showed that the interaction of the normal brain after 5LA administration and fluorescent administration with ultrasound doesn't cause any harm. And these are good data, and we are trying to start a clinical trial here in Milan. This is an overview on all the application of therapeutic ultrasound for everything. You can see from cardiovascular to neurological disease to neurological and pain, gastrointestinal. And we are slowly moving forward towards FDA approval and reimbursement. But we are still in an early phase. And regarding brain indication, as I mentioned before, movement disorders is the main clinical application, essential tremor and Parkinson. But the other applications such as Alzheimer's disease, stroke, brain tumors are gaining a lot of space. So I just want to invite you to the next virtual, of course, symposium of the Focus Ultrasound Foundation, which will be held in November 2020. And thank you for your attention.
Thanks very much, Francesco. Thanks for always showing us a different perspective and taking it a step higher. Yeah, and I was very supportive of the Focus Ultrasound Foundation and Cassell, and like you say, Jeff Elias, and now yourself, driving this quite hard. I hope it gets to sort of realize a lot of the potential that it promises. So we're going to move on to the next part of our talk, which is a bit of the highlight of this webinar. So Alessandro Perin works in the same institute that Francesco does, and they've been driving quite hard this neurosteam simulation thing. So I'm going to get Claire, if you don't mind, Claire, just to walk us through this quickly, and then Alessandro will follow on with his talk.
Perfect, sure. So I have sent the link through in the chat box where you are able to click, and I have placed a slide on the screen. So basically you just need to obviously click on the link. It'll take you through to your web browser, and you just need to click the register button. Fill in all of your details and click submit. And then what you'll do is you'll go to the login, where you'll click login, and then it will take you, you'll enter your username and your password, and then you'll be logged into the NeuroStream system for the next speaker's talk.
Okay, thanks, Claire. And with that, I'm going to hand over to Alessandro. Alessandro, it's a real honor to have you involved in this. So you've done a tremendous amount of work, you and Francesco D'Amico, driving this sort of virtual simulation program. So I'm going to let you go ahead now. Thanks so much, Alessandro.
Thank you very much. Thanks to all the participants for being here and resisting for such a long time. Let me see if I can. I wonder if you can see my.
It's not sharing at the moment yet.
Doing it right now. Okay.
Okay, great. There we go. Thanks.
Now, good. Okay, so as you said, we are trying to make something unprecedented and completely new. So the first online intraoperative ultrasound simulation session for neurosurgeons, and I would like to thank Professor D'Amico and all the MASMEC guys for the tremendous and terrific work they did in order to get to this point. So what we're going to do today is test with a beta version of our platform. And I would like to introduce you to that without any further ado. So I would like to start from here. So we are neurosurgeons, and we are somehow some funny guys. First of all, because we love ourselves a lot, but mainly because we don't like to waste time. And I really found interesting your comment on Dr. Forbes, who was commenting about the introduction and implementation of a stethoscope. So we don't like to waste time, in particular in the OR. That's why a few years ago, we invented this application and device, which we call IOUS. We published that, and you can find all the tech specs in this paper. Basically, the bottom line was to allow you to rehearse and simulate intraoperative ultrasound outside of the OR. So to take advantage and to exploit the experience that we collected here at CBESTA in order for all of the people interested in intraoperative ultrasound in neurosurgery to get enough experience, enough knowledge, enough understanding of the intraoperative ultrasound semiotics before going to the OR. Is that effective? Yes. If we ask some participants to identify 10 landmarks without any experience, or even with some experience in intraoperative ultrasound, this is what you get. So 6 on average landmarks can be identified relying only on intraoperative ultrasound, but with only one application of IOUS, basically all of the participants are able to identify all of the structures that you show to each one of the participants. So the result was striking, I think. That's why we decided to implement this application inside this new platform, which is called NeuroStream. You can log in, and I'm sure that you registered already, to neurostream.academy, and you can find, this is the web address. It's a two-sided, double-face platform. It has a social room and a medical room. How does that work? Basically, we want it to be like Facebook, so like social media that we are all familiar with. So you can see the posts that you can publish, whatever. You can post something about your personal experience or some neurosurgical procedures that you like, or some difficult cases that you want to share with your colleagues for further discussion or to get some comment or advice by your peers. You can do many things also in the medical room, where you have a library of cases that we have already operated on, and for those we have also collected matched and paired preoperative MRI images with intraoperative ultrasound images. So this is like a gem that you wanted to share with all the world of people interested in intraoperative ultrasound, where you can find a whole bunch, series of cases that we've operated on, match preoperative MRI with intraoperative ultrasound data. So that allows you to simulate, and this is what we're going to do in a few minutes. And you can do it as free navigation, or as we are going to do today, in this modality, IOUS learning, with the code that we provided you with. I would say that we can start doing it right now. So what I would like you, and I recommend you to do, is to go to neurostream.academy, enter your username, and then your password, and log in. So for those of you who want to do that today, we can do it together. For those of you who want to do it in the upcoming 2 weeks, don't worry, you have time to do it in the privacy of your room, in your office, wherever. You have 2 weeks to use the code that we're going to provide you with, and you can practice even outside of this session. So that's very important. You can relax if you don't want to do it today. So I hope that you already have logged in. You have to switch off your microphone and video, which should already be like that. Then you, from Zoom, you enter the menu and you keep on top Zoom. Then on the small menu, you select the second button here, so that you can also enlarge or decrease this video screen. That's important because I'm going to show you how to use your mobile phone. So your mobile phone will be like a virtual probe for you to do like real intraoperative ultrasound. So you go to the website, you log in, like we said, and after you log in, you enter the medical room, okay? So you enter the medical room, you can scroll the library, and you select this first top left case, okay? So you click on that, and the case, we can, before we actually enter the real simulation, I would like to show you what we are talking about, what kind of case. So is this right frontal solid and cystic tumor. This is the appearance on a coronal section, and this is on a sagittal section. And remember that the head of the patient will be positioned like that. So for your simulation, that's how the head is positioned. And you're going to position the probe right where we are going to make the craniotomy. Okay, so that's the appearance of the structure, and we're going to ask you to identify some tumor landmarks and some normal anatomy landmarks. So that's very important for you to get familiar with this MRI. That's why I'm scrolling it and showing you how it looks like, how the ventricles are displaced, and also on the sagittal section. You see it here. how everything is compressed, corpus callosum, anterior cerebral arteries. So having said that, we're going back to the presentation, which is this one. So you can click on simulation, and then you enter here in IOUS Learning the code that you need, which is IOUS 2020. So please write it down, remember this code. So intraoperative ultrasound 2020. You enter the code, then you click on get started. For those of you who want to do it today, otherwise you can do it in the upcoming days, no problem. I'm going to show you how to do it, no matter what. So this is very important. How to pair your smartphone, which will be your virtual intraoperative ultrasound probe, with your laptop. So that's very important. So first, you have to switch on the camera on your smartphone. So let's do it together. So I switch on my camera. Okay, so now my camera is on. So mind you, it's easier if you have an Android. With an iPhone, it's a little bit more complicated, but not that complicated. So I'll guide you through, don't worry. So once you switch on your camera and you click on IOUS simulation, you should see this QR code on your screen, okay? So what you're gonna do is you go close with your camera, you capture this QR code, and then you click on this web link on your smartphone, and you should be guided to this device pairing page. So you have to allow this function on an iPhone, and then you're gonna be asked to do that again, okay? So that's very important. Let's go again there. I'll show you how to do that. So you click on that, you pair, you allow, and that's very important. Now I show you something extremely important, which is this, okay? So I'll do it myself. So medical room, IOUS simulation. Click here, IOUS Learning. With your camera on, you go close, you click, you allow. So it is already paired. I'm tapping on my screen. I allow the application to do the pairing. Then screen reference, again, I tap in the center of my screen. And you see now, I'm moving slowly my smartphone, which is now my probe. And you see how that moves on the screen, consistently on the head of the patient, you see? So now I'm tilting my probe like that. Then I turn it, and I can move it also on the sagittal plane, okay? So this is what you're supposed to be seeing on your laptop if you did everything properly, okay? So now I'm seeing sections on a sagittal plane, see? Now I turn it on the corona plane, and you see this green line here on the top of your screen? That's very important, because this is the task that you're going to be asked to. So you have to identify 10 different landmarks, either within the tumor or outside, and you have to outline them. How can you do that? So you click when you think that you identify, like in this case, the cystic component of the tumor. So I click on that, and then with my mouse, I can outline the cystic component if I think that this is the cystic component. I'm not happy with that, so I can cancel that. I find a better plane, like here, and I see better my cyst. I outline it, and then I check it. Then you move it to landmark number 2. So mind you, you have a limited amount of time, so that's how the exercise is supposed to be. It should be challenging for you. So now you should identify the solid component of the tumor. Maybe, I don't know, is it this one? I don't know. So I check it. You can also change the IOUS control. So that's the beauty of it. You can increase the gain, you see, or the power. You can decrease or augment it to the maximum. Or you can enlarge or zoom out or zoom in. You can flip, freeze. You have multiple functions, but I would say that probably the gain is one of the most useful ones. And still, you can always move your probe like the way I am doing, so also on the sagittal plane. And you have to identify different structures. Now something anatomical like the fox. Then you have to outline it. So where is it? Maybe here, I don't know. Then you check it. And at the end of the exercise, you're gonna get a score. So let's say that now I'm done with it, okay? I'm done with the first phase of my test. I can click here and move to phase number 2, which is now the teaching modality for this exercise, where you can see a coplanar preoperative MRI with intraoperative ultrasound. And this is the most useful part of the exercise for people who are not familiar with IOUS semiotics, because now you can really tell precisely what is the solid part of the tumor, the cystic component. Then you may see clearly where the ventricles are, where the corpus callosum is, because now you can compare where the fox, and then you can get some nice nuance of intraoperative ultrasound, like you could realize that the fox is hyperechogen, or hypoechogen is the corpus callosum, and then you can see how the choroid plexus look like inside the ventricle. So you get a very detailed and thorough understanding of how a brain looks like when you use intraoperative ultrasound. Like in this case, you can nicely identify the choroid plexus inside the lateral ventricle now, or the corpus callosum, you see, hypoechogenic, or the cingulate gyrus here. Now you know what is what exactly. You see how the tumor looks like, you see the cystic component here. These are probably the pericallosal arteries. Even here, you have the chance to outline and tell what is what. So like in this case, you can outline the structure that you want to show yourself and the examiner. And when you're done with this, you go to the final part of your exercise, and always with your probe, you orient it the way you want, like in this case. So probably we have too much gain now, so I can decrease it. And now, hopefully, you should be more confident and precise in, for instance, defining what the cystic component of the tumor is, okay? So you outline it, then you check, and everything is recorded, and it's gonna be made as a PDF at the end. So once you are done with your exercise, you click on that, and you get a result table, okay? You can download it, like the way I am doing. So you see, you get a PDF where you can see all the screenshots of your recordings. So you can precisely track your progress from the very beginning until you become a master in intraoperative ultrasound. Once you download your file, you can save it, let's say on your desktop, name it whatever you want to name it. And then you can publish it. How? You go to social room, because what we would like, and this is also something very interesting for you, is that if you're going to do this exercise in the future during the upcoming weeks or anytime, you can share this with me, with all the faculty, because we're going to be interacting and discussing everything here. So in this case, I would like to upload my result. I go here, upload file. Say I call it IOUS results, and I can select the file that I want to upload. It should be this one here. Okay. And then I can add it. So this will be visible on the wall on my personal homepage within neurostream.academy. And the idea would be that we are going to use this platform to share information with our peers, with our colleagues, to discuss not only intraoperative ultrasound cases, but also other cases that we would like to get some feedback from the other members. And this is a new feature that we just implemented, is the conference room. So conference room is something very interesting for us because it uses Zoom. So it's super easy. And maybe next time we're going to be doing this meeting, this webinar through neurostream.academy. So you can schedule any kind of meeting you want with different people. You can invite, members from belonging to our community. Like in this case, I want to invite my friend Daniel, and I can call this like whatever I want. I can schedule it anytime in the future and set the time, and then I publish it and I'm done. So next time we want to do, let's say, discuss about something, do a grand round, whatever, we can use this platform, and I think it should be something fun to use and useful, which would eventually spread the voice of intraoperative ultrasound with a larger and larger community every time. So I think that we have some more time for those of you who still want to practice and do some more simulation in the medical room. I'm sure that now you all know how to do it. Something that probably I haven't mentioned early on was that we have a huge library of cases that you can scroll through and rehearse, and I think it might be useful for expert users, as of course for non-expert users. So it shouldn't be something intimidating, it should be something friendly, user-friendly, I hope. And we would like to have your comments and feedback again in the social room of our platform. So please feel free to interact. This tool was made for us, for you, so use it, and I hope you enjoyed this session.
Thanks, Alessandro. That was a tremendous effort. I must say, I managed to follow a lot of it, but we'll ask for some feedback. And what I'll do is we'll add a question at in our questionnaire just to get some feedback from the users. I see we had one question from Dr. Gurmeet Singh asking for the code to be repeated again. So maybe I could ask, can they use that same code over and over every time, or do they need a new code?
Yeah, absolutely. Yeah. So maybe I can share it through our chat, which is something probably useful. It's super easy. So intraoperative ultrasound 2020. That's the code for endless intraoperative ultrasound simulation. Okay, so that's the code. Maybe, there was no capital here, so like that. Yeah. So there was a capital I at the beginning, which was a typo, and automatic correction. So it's small caps. Yeah.
Okay, so IOUS 2020,
Yeah,
all
yeah,
small, yeah?
With all those small caps, yeah.
Okay, great. Okay, so I think we've got a little bit of time. If there are any faculty comments, Geirmund, maybe if you wanted to add something, this would be a good time, Geirmund?
Yeah, I think it's the thing you have made here, Alessandro, and your group is very, very impressive in my view. So I think this is going to really increase the learning all over the world. And I've seen you present this earlier, Alessandro. I think it is all the time improving. So now it was really good. Thank you.
Well, thank you, Geirmund. I mean, if you say so, I trust you. I mean, it's really flattering. Thank you, Geirmund.
Yeah. Okay. Thank you, everyone. I see we've got a few thank yous, but no questions. We've managed to keep very well to time. So thank you very much to all our tremendous faculty. Thank you, Alessandro. Thank you, Francesco, Aliasgar, and Geirmund. And thanks to all our participants from really sort of such a wide spectrum, a really international crowd.